Here today is about breastfeeding of a preterm baby. So right now, if you see in the picture itself, you see these little babies here with so many gadgets coming out of their mouth, coming out of their nose. It seems totally scary. Is this going to this? It's going to be a big challenge feeding these preterm babies, and even as mothers, they would think, how am I going to exclusively breastfeed my preterm babies? So let's walk through this process first. So just to, as Rashmi just told us, this is the logo of this year's breastfeeding week. Protect breastfeeding, a shared responsibility. So even though the mother is most of the mothers are motivated mothers that they want to breastfeed, as healthcare professionals, it is a shared responsibility on our side too, to help them as much as possible and motivate them with all the good ideas of how good breastfeeding is, so that they do exclusive breastfeeding for all their babies. So today's talk, I would be just starting about a little bit of importance of breast milk, which as Rashmi has extensively covered in just a few slides. How preterms are different, what is the extra nutrients in these preterm milk, which is important to these preterms, so that that mother who delivers the preterm should start pumping from day one, so that that baby who is a preterm requires all the extra nutrients in that milk, rather than using milk from a human milk bank, which could be a term milk, as far as possible. Express breast milk storage, Rashmi had gone through, but a little bit of I'll touch on it. Words like NNS and KMC, which I will talk about, which is very much important in the process of these preterm mother able to give her own milk to her baby. And finally, how these babies transition to direct breastfeeding, I will talk about. So start off again and again seeing breastfeeding is the best for all our babies. And I motivate all the mothers who are listening to this as participants to breastfeed their babies, as it has been age long and not changed to bottle feeding. So why is it good? I think Rashmi has extensively spoken about it. Just to say, every organ is protected by breastfeeding, from brain development, eyes, teeth, respiratory, lungs, tummies, long-term development. Everything is best with breastfeeding. So it's the God's gift to mothers to breastfeed their babies, right? Now, I'm going to talk about these teeny weeny preterms compared to these term babies who look very well fed, on how we are going to get them up to this size by using your breast milk. Okay, so what is different with preterms? These are small babies which very less weight, right? And all the organs are immature. Normally, what are preterms? Less than 37 weeks. Normally, a term baby is born around 40 weeks, 38 to 40 weeks. These preterms are born less than 37 weeks. They can be as small as 24 weeks, which could be just half the gestation, nearly half, 6 months of life. The babies are out into the world. So they're very, very small in size. They have such immature organs like breathing organs, brain, digestive organs, stomach, everything is immature. They have a very fragile skin, so they can't maintain their temperature. That's why they're kept in these boxes called incubators, where they can maintain their temperature. They have so many feeding issues. That's why they have tubes to their nose, which I'll talk about. And they have an intravenous line through which fluids are given, because they can't feed immediately. Immature digestive system, which can get infected very easily, and other issues like jaundice and growth and development issues. So that's how they're different from a preterm baby, from a term baby, because they have so many problems which has to be handled. So the biggest issue we'll be dealing here is, because of the breastfeeding, is the feeding issue. So why should you breastfeed your baby is one question, and how can you give breast milk to your preterm is another issue. So first thing is, we have to understand that the sucking and swallowing, which is very, very important for a baby while breastfeeding, does not come in a coordinated way. So you suck, the baby sucks the milk and then has to swallow the milk. This requires extensive coordination. That develops only by 32 to 34 weeks. These preterms less than 32 weeks, they can suck, but they cannot swallow. And then they can't coordinate it with this breathing, and then they stop breathing and they sometimes aspirate their milk. So till then, they can't be fed through their mouth. The other biggest problem with preterms who are very small, less than 28 weeks, is the biggest risk of necrotizing enterocolitis. What does this mean? Is that this is our little intestine, which loses its blood supply, becomes black stuff is lack of blood supply, and the intestinal walls die. This kind of condition can be totally prevented by using breast milk for our preterm babies. So that's the key point of why we say exclusive breastfeeding for these tiny weeny preterms whose tummies can be this big and they can lose a part of their intestine just because of formula feeding. Then a lot of preterm babies can reflux milk because the sphincter which prevents the milk from coming from the stomach to the food pipe above is not very patent. So that is one problem. And they can't take huge amount of milk immediately. So they have to have small, frequent feeds for a long time. So how are we going to feed them? We put this little tube through their nose, which is called the nasogastric tube, which is going through the nose, going to the back of the nose, coming all the way down to the baby's stomach. We feed the babies through this tube till they get the suck-swallow coordination, which is going to be 32 to 34 weeks. So this is a baby which is fed with a nasogastric tube. So the milk is given through a nasogastric tube and goes into the baby's stomach. So different ways. This is called the gravity way, where they hold up the syringe there, and then the baby is fed, and see how it's getting its tummy filled and peacefully sleeping. The mummy feeding the baby through a nasogastric tube, which is on oxygen supply. If she carries and holds the baby, it gives more of a bonding to the mother. And she's happy it's her own milk which she's giving her baby. So how do we get this milk from the mother, right? So Rashmi did speak about the express breast milk, which we have the pump in our hospital, which they can do dual pumping also. This expressed breast milk is used for the baby. The biggest 4 days, the mother gets the colostrum, which has high antibodies. This is what the preterm needs because these antibodies go and coat the baby's tummy, the baby's respiratory tract, and prevents the babies from getting the necrotizing enterocolitis I was talking about, helping the baby's respiratory tract from getting infections, and all the infections which the baby can acquire is being protected by this colostrum, which the mother gives, which is exclusively produced by that preterm mother for her preterm baby. Then after 4 days, she started producing the transitional milk and the mature milk. So what is the difference? Why can't we use donor milk, right? That's the biggest question, which we have in a lot of human milk banks. The biggest thing is these preterm mothers produce milk which is high in protein, which is exclusively produced by her, compared to the term mothers which produce a lower protein. And these preterms need this extra protein to build up their muscle mass to grow as they mature in age. The other important constituents of the preterm milk, which is very essential, is the iron. The iron content is really high. The vitamin A, which is very, very important for vision, for avoiding retinopathy of prematurity, and also for preventing lung injury to the baby, is very high, and vitamin E. So all these essential nutrients are very, very important for a preterm baby and can be is maximum present only in a preterm milk. Storage she spoke about. I won't go back to it again and again. So only thing we can say is we can deep freeze it up to 6 months and keep it in the refrigerator for about 24 to about 3 to 4 days. So what is happening with these mothers who's expressing? Why should she express and how often should she express? So emptying of the breast is very, very important. Only then the breast keeps refilling, right? Instead of sucking, we're using the pump to express milk, which is telling that there is some amount of ejection happening in the breast so that the reflex is there and then more filling happens by expression. Very important is nighttime feeds. Why? This hormone prolactin for some reason is only produced maximum at night. So the mother should be motivated that at least she pumps at least a couple of times at night, in which the breast thinks, oh my God, maybe the baby is there. And that's why the mother is pumping. And that will increase the milk production for these mothers. But unfortunately, these mothers who are expressing the breast milk, they do not have the skin to skin contact, which stimulates the express more milk production. And we do have, infection issues because the milk is pumped into a container, needs to be handled and transferred. And as like a normal baby, there is not enough suckling at the breast. But how can we replace all this? All this happens in a term baby. The skin to skin contact, the frequent suckling all night. When all the term mothers, when you go for your postnatal rounds, says, "Madam, தூங்கவே இல்ல, madam, night எல்லாம் feed பண்ணிட்டு இருக்கு," right? That kind of thing is not faced by a preterm mother. And how does she get motivated to keep pumping? And how does her milk supply increase? So that's when comes the kangaroo mother care. Like how like this little Joey, which is even though it becomes a big kangaroo, still the mother carries her around in her little pouch, right? So this gives the baby a little of comfort and bonding. From that, we got this theory of KMC for all their preterm mothers. So what we do is we put these little babies, which are in some amount of support, oxygen support or CPAP support, on the mothers, skin to skin, with a little binder around. And this kind of bonding gives her a feeling that her baby is on her. And that makes her produce a lot of milk. This bonding itself gives her a lot of confidence and makes her feel happy. And this nuzzling actually contact produces more breast milk in the baby. So we can always use the mothers to, teach them how to, do the gavage feeding also. So that gives them a sense of feeling that they are doing everything for their child and give them. So how does this KMC help? Main things it helps is, it helps in effective thermal control. The baby is skin to skin with the mother. So the baby is able to maintain its temperature very, very well, which is biggest problem in preterm babies because they have a very thin skin. They can lose a lot of water and heat from their skin. So the skin to skin with a little binder around actually gives a lot of thermal control. The smell of milk in the mother makes the child root. So it promotes all the reflexes in the baby. And it's the biggest thing is a prevention of infection. The more and more the babies are in the mothers with KMC, the risk of infection is very, very less because they transition to breastfeeding faster and they can get discharged faster because their growth is higher. And this also gives the mother a very good, secure feeling and very good bonding with the baby and the mother. So actually KMC has in the West and all over the world has shown that kids or babies, preterms who are on KMC for as soon as possible are very early, get discharged very early from the hospital compared to neonates which do not have KMC. That is okay. So now we've had this KMC, bonded the mother, the baby is starting to root around and wants to suck now. So how do we promote the suck? There are two ways we can promote the suck. The baby's already, one thing is we can use pacifiers, which are sterile, which are actually, we have to, sterilize them and use it for these babies. This promotes suck for babies who are younger than 30 weeks, one way. And once we realize that they can suck, then we can do this called non-nutritive suck. What happens is this is the baby still has its NG tube in its nose. We have to let the mother pump the breast, empty it, and then nuzzle the baby with the mother's breast. That way it takes small frequent sucks, which is called non-nutritive suck. This way the baby's suck is promoted. And by 32 weeks, when the baby goes on the breast, it's not a different feeling. All it has to do is whatever it sucks, it has to learn to swallow. So this non-nutritive suck should be started very early in preterms, so that sometimes if you don't start it very early, then they do not suck at the breast at the time when they have to. So this is a very, very important part of preterm care by which they can transition to breastfeeding earlier. So after this non-nutritive suck and the baby sucking on the empty breast, even though we can transition then to breastfeeding, these preterms are still tiny, and the effort of breastfeeding, they get tired out. So they can't gain weight if you put them directly on breastfeed from 32 weeks when they're less than about 2 kilos, 1.5 kilos, because they take a few sucks, they get tired. So we have to give them the chance of sucking at the breast, and the rest of the milk can be given either through palade feeds or cup feeds. In our country, palade is very popular, and most of our preterms go home on palade and direct breastfeeding. So this way they suck, but then the swallow is easy because it's slightly poured into the baby's mouth and the effort is less. So we can do the suckling and then on the direct breastfeed with a little bit of a half partially or empty breast, and then breast can be given by Pala Day till they're about 1.82 kilos, and then they can transition directly to direct breastfeeding. Then finally, we have the direct breastfeeding. Most of our babies, I'm proud to say, in the IRM have gone home on direct breastfeeding. Thank you.